Sir, we are now Facebook Live. You
Thank
can
you.
start the program, sir.
Assalamu alaikum. Good evening. Welcome you all to today's IPDI virtual classroom. We again start classroom on Friday at 10 p.m. Welcome everybody. Today's topic, everybody, MPI is a big chapter, but we know the basics of MPI and clinical implications. This program is actually designed for the fellows, MD, diploma, and FCB students. But I think this subject is so much not popular for the cardiologists also. So we are grateful for the Shankar kind consent to be here with us. IPDI is grateful to you. Welcome you. It's a short description, short introduction for the Shankar Kumar Biswas. I just few words for him, for our fellows. We know everybody. Professor Shankar Kumar Biswas is now Professor and Chief Medical Officer, Head PAT-CT, Nuclear Cardiology Division, Institute of Nuclear Medicine, Allied Sciences, Dhaka Medical College Hospital Campus, Dhaka, Bangladesh. His area of work in nuclear medicine, ultrasonography, including duplex, color duplex, cardiovascular imaging, PAT-CT scan. But his field of interest as college for his own interest. We are really grateful as a cardiologist. He's a clinician, also a nuclear medicine specialist. He's also good academician, but he's lots of research work on color duplex sonography, peripheral vessels, obstetric duplex, carotid duplex, flow-mediated dilatation of bacterial table, diabetic nephropathy, renovascular hypertension, musculoskeletal ultrasonography, microdial perfusion and fatty acid metabolism, coronary CT angiogram, and cardiac MRI. We have lots of publications also. We welcome Mr. Shankar Kumar Biswas to today's program. I am requesting all the participants, please mute yourself for concentration of his talk. I am requesting Professor Wadud to this, sir. Please open your session and just comments on this lecture. Thank you.
Good evening, everybody, and Assalamu alaikum. Welcome to you all. Today, we are going to hear from Professor Shankar Kumar Biswas about one of the mechanism of assessing myocardial viability, the need for the point of interest of cardiovascular revascularization. This is important. We are not doing only simple PCI or simple intervention. We are doing some very complex ones. Now we are doing post-bypass patient, very low ejection fraction patient, very elderly patient, very calcified lesion, and all these will be beneficial to the patient if the revascularized area really has some viable tissue. And that's where the MPI is so much helpful to us. It can guide us. It can help us to devise our plan, what to do, how to do, which vessel to touch, which not. And this is because of non-availability widely has not been practiced that much in our country, but this should be. Now is the time our young stars should make themselves very adept and adopt this method of assessing which vessel to revascularize. And Professor Shankar, he has been dedicating himself from the very beginning. When he returned after doing his PhD in Japan, he made contact with us at Dhaka Medical College. I think that's back about 2009 or 10. Since then, we have been trying to help him grow his field of interest, and he has been trying as much to help us to deliver better service to our patient. He's very dedicated, very humble, very knowledgeable, very helpful. And I hope today's talk will enlighten all of us together. Dr. Shankar, Professor Shankar, we are really grateful that you are with us. Now, Professor Mohsin, you can carry on. Thank you, everybody.
I think network problem. Professor Shankar is out of our network. Professor Mishka, sir, do you hear me, sir? We have a plan to arrange a session like viability test with the Professor Shankar here, Dr. Azad, Dr. Nusrat here, Professor Tuhinok here. I think Mishka, sir, we design next month as a session. Mishka, sir, please.
আমরা তুহিন হককে we can ask তুহিন হক because her PhD is on dobutamine stress echo. If she is kindly give her consent that she will be showing us the dobutamine stress echo and its role in assessment of the viability, সেটা সবচেয়ে ভালো হয়। তুহিন তো আছেন?
আমি আছি। আমার পিএইচডি আসলে শুধু dobutamine stress echo না, আমার myocardial hibernation, এটা নিউক্লিয়ার কার্ডিওলজি প্লাস স্ট্রেস echo। নিউক্লিয়ার কার্ডিওলজির মধ্যে আমি থ্যালামাসকে ইমেজিং করেছি, ফ্যাটি অ্যাসিড ইমেজিং করেছি। কাজে আমার নিউক্লিয়ার কার্ডিওলজি এবং মানে একো দুইটাই আছে। একো বলতে রেস্টিং একো, ডাবুটামিন একো সবই আছে। এখন আপনারা যদি পার্ট বাই পার্ট করে দেন তাহলে ঠিক আছে, কিন্তু আগে থেকে একটু আমাকে টাইম দিতে হবে যে কতটুকু সময় এবং আমাকে কোন পার্টটা দিবেন।
মানে আমরা একটা ম্যাডাম ডিজাইন করতে পারছি যে আসলে ভায়াবিলিটি নামে হবে, ভায়াবিলিটি নাম হবে টেস্ট ইয়ার নাম, সেক্ষেত্রে
সিম্পোজিয়ামটাই ভায়াবিলিটি নামে হবে।
সিম্পোজিয়াম লাইক ভায়াবিলিটি বিকজ ইট ইজ ইগনোর পার্ট ফর দ্য cardiologist and surgeons. So you should raise your voice. So with like a seminar symposium, you madam and also Mishka sir, Ojoy here, Nusrat Gopur here, Professor Shankar also here, we can design a program slot as like a viability test only. Mishka sir, please.
হ্যাঁ, তুহিন খুব ভালো হয় আপনি মানে একর পোরশনটা নিলে, এবং যদি নিউক্লিয়ার পোরশনটা আপনি আমাদের প্রফেসর শঙ্করের সাথে ইসে করতে পারেন। কি যে নিউক্লিয়ারের ওরা নিউক্লিয়ার পার্টটা বলুক, আর স্ট্রেস ইকোর পার্ট আপনি বলেন, আর এমআরআই পার্টটা আমার যারা আমাদের এমআরআই লোক আছে তারা এমআরআই শুধু ভায়াবিলিটির উপরে একটা থরো
বলতে পারে।
এটা হলো যদি নিউক্লিয়ারের মানে কিছু আপনার অ্যাড করতে হয়, নিউক্লিয়ারের পার্টটা আপনার দুজনেও বলতে পারেন।
ঠিক আছে, একুশ সাথে নিউক্লিয়ারে যতটুকু কম্পারিজন আমার স্টাডিতে আমি যেগুলো দেখেছি আমি সেটাই বললাম। আর যদি আরেকজন মানে টোটালি প্রফেসর শঙ্কর নিউক্লিয়ার কার্ডিওলজিতে বলতে চায় সেভাবে বলবে, তাতে কোনো অসুবিধা নাই।
হ্যাঁ, আর এমআরআই থেকে আমরা সিলেক্ট করব যাদের কেস করা আছে এরকম।
সেটা আপনার আমাদের অজয় বলতে পারে, ও তো আবার ওইদিকে কাজ আছে।
আমরা থিওরি না বলে আমরা একটু যদি কেস বেস ডিসকাশন করি, already we are going on we can arrange a session lecture for 50 minutes lecture next month, only dobutamine stress echo. Madam, you can agree only dobutamine stress echo on next month. Then on the month of April we can arrange a symposia on viability, like case based discussion on viability, not like theory. We can discussion any problem like Mishka sir also in lots of cases, you also Dr. Usmani also some cases on. Okay, Shankar sir is here. Professor Shankar, okay. Okay, we are hear you and see your slide. Let's start. স্যার ঠিক আছে, দেখা যাচ্ছে আপনাকে দেখা যাচ্ছে, শোনা যাচ্ছে। আপনি শুধু আপনার প্রেজেন্টেশনটা ওপেন করেন। সব ঠিক আছে স্যার, বারবার শুনতে পাচ্ছেন আমাকে?
ক্লোজ করে যে প্রেজেন্টেশনটা
পাওয়ার পয়েন্ট বের করেন।
তুমি শেয়ারে গিয়ে তোমার পাওয়ার পয়েন্টটা অন করে দাও। সৌরভ, ক্যান ইউ গাইড হিম?
আমি ফোন দিচ্ছি স্যার, অলরেডি আই হ্যাভ গাইডেড হিম স্যার, আমি আবার ফোন দিচ্ছি।
শুনতে বলো, ইজিলি হয়ে যাবে। মিশকা স্যার, আমাদের এখানে যে এমপিআই ক্লিনিক্যাল ইমপ্লিকেশন আসলে কি কি হচ্ছে, আমাদের আসলে কি কি দেখা হচ্ছে, বাংলাদেশের সিনারিও কেমন স্যার?
আচ্ছা, বাংলাদেশের সিনারিটা সবচেয়ে বেশি দেখা হয় যেটা, সেটা হলো ইনডিউসিবল মায়োকার্ডিয়াল ইসচেমিয়া। স্পেক্ট এমপিআই যেটা, পেটটা খুব আধুনিক, মানে অল্প সময় হয় আসছে, পেটের ব্যবহার খুব বেশি এখন পর্যন্ত হচ্ছে না। আর ভায়াবিলিটি দেখার জন্য কিছুটা ব্যবহার করা হয়। আর এর অনেক আগে যখন প্রথম শুরু হয় নিউক্লিয়ার ইমেজিং, যখন আমরা খুব ভালো আমাদের এলভি ফাংশন আরবি ফাংশন দেখার জন্য স্ট্যান্ডার্ড কিছু ছিল না, তখন কিন্তু রাইট ভেন্ট্রিকুলার ফাংশন দেখার জন্য নিউক্লিয়ার ইমেজিংটা ব্যবহার করা হতো, আরবি ফাংশন, এমনকি এলভি ফাংশন দেখার জন্য। এখন এলভি ফাংশনের জন্য তার এটা রোল তেমন নাই, কিন্তু আরবি ফাংশন দেখার জন্য অনেক সময় এখনো, বিশেষ করে রিসার্চ পারপাসে, বাংলাদেশে মনোয়ার স্যার আমাদের প্রথম দিকের এমডি, ওনার রিসার্চের টপিকসটা ছিল রাইট ভেন্ট্রিকুলার ফাংশন ইন ইনফেরিয়ার মায়োকার্ডিয়াল ইনফাংশন, উনি মায়োকার্ডিয়াল পারফিউশন।
শুনতে পাচ্ছেন আপনি? আপনাকে আনমিউট করুন, আনমিউট করুন।
শঙ্কর, আনমিউট করো তোমার।
হ্যাঁ, আনমিউট করেছি স্যার।
আপনার শেয়ার স্ক্রিনটাকে আপনার প্রেজেন্টেশনটা ওপেন করেন, প্রেজেন্টেশনটা ওপেন করেন, ডেস্কটপে ওপেন করেন বা ল্যাপটপে ওপেন করেন।
হ্যাঁ, ওপেন করছি স্যার।
একদম ওপেন করেন আপনার স্লাইডে।
স্যার কাইন্ডলি শেয়ার স্ক্রিন দিন।
এন্ড নাও শেয়ার স্ক্রিন। ওকে,
হ্যাঁ, শেয়ার স্ক্রিন দিচ্ছি স্যার।
না থাকছে না কেন? আপনার প্রেজেন্টেশন কোথায়? প্রেজেন্টেশন ওপেন করেন,
সেটা আগে ওপেন করেন।
এই যে ডেস্কটপে স্যার, এই যে আমি ওপেন করছি স্যার।
না ওপেন করেন, ওপেন করেন। হ্যাঁ, রাইট, ওপেন হচ্ছে, একটু স্লোলি করেন।
এই যে স্যার, এটা ওপেন হচ্ছে।
ওপেন হবে।
হ্যাঁ, ওপেন হয়ে যাচ্ছে স্যার। এই যে রোমিং হচ্ছে, এখন ওপেন হবে আশা করছি। এই যে স্যার, ওপেন হয়ে গেছে।
হয়ে যাবে। ক্যান্সেল দেন। ক্যান্সেল। ওকে, হয়ে যাবে, এখন হয়ে যাবে।
এই যে স্যার, ওপেন হয়েছে স্যার।
রাইট।
হ্যালো।
হ্যাঁ, হচ্ছে।
হ্যালো।
ওকে, এখন বিগ স্ক্রিন করে দেন।
হ্যালো।
বড়।
হ্যালো।
শঙ্কর,
হ্যালো, দেখা আছে।
এটা ক্লিক
বড়
করো।
করেন, বড় করেন।
হ্যালো।
হ্যালো, সব ঠিক আছে, এভরিথিং ফাইন।
তোমার কাপের উপরে ক্লিক করো এখন, তোমার যেখানে আছে
ক্লিক করেন
ওই কাপের রাইট।
ক্লিক করেন। ওকে, গুড।
হ্যালো।
এভরিথিং ফাইন। স্টার্ট নাও।
ইউ ক্যান নাও।
হ্যালো।
আপনি শুরু করেন, সব ঠিক আছে। আপনি সাউন্ড ক্লিয়ার, ছবি ক্লিয়ার, সব ক্লিয়ার। আপনি শুরু করুন।
হ্যালো।
সব ঠিক আছে,
স্লো।
আপনার সব ঠিক আছে, আপনি শুরু করুন।
হ্যালো।
হ্যাঁ, সব ঠিক আছে দাদা, স্যার, সব ঠিক আছে, আপনি শুরু করুন। আপনাকে দেখা যাচ্ছে।
ও, হ্যালো।
আপনি সব ঠিক আছে দাদা? নেটওয়ার্ক স্লো।
ওকে ফোন না করলে শুনতে পাচ্ছে না। শঙ্কর, তুমি কি শুনতে পাচ্ছ আমাদেরকে?
স্যার আমি ফোন দিচ্ছি স্যার, স্যারকে একটু কাইন্ডলি ওয়েট করুন।
আপনার সব দেখা যাচ্ছে।
হ্যালো।
আপনাকে দেখা যাচ্ছে।
আমার মনে হয়
শোনা যাচ্ছে স্যার। আমি আচ্ছা, আমি স্লাইড প্রসিড করব।
হ্যাঁ, রাইট।
কিন্তু আচ্ছা, কিন্তু ওই সাউন্ড সিস্টেমটা যেন ভালো ক্লিয়ার হচ্ছে না আমার কাছে মনে হচ্ছে। আচ্ছা, ঠিক আছে আমি প্রসিড করছি তাহলে। ওকে স্যার।
ওকে, ফাইন।
Okay, so I would like to start my program here, and I'm very much grateful to the organizing committee of this program. I mean, Integrated Professional Developments Initiatives Program. In this Corona pandemic, actually, this is a very nice initiative. I must appreciate Professor Wadud sir and Mohsin sir for their unbound support and continuing this program. Today, I would like to continue my talk with MPI and its applications. Actually, there are several cardiovascular imaging modalities: echocardiogram, ECG, peripheral vascular Doppler, coronary angiogram, intravascular ultrasonography, optical coherence tomography, cardiac CT, cardiac MRI, and my part, nuclear cardiology. I mean, SPECT and PET, single photon emission computed tomography and positron emission tomography. nowadays we can fuse these two images also in my center, Dhaka Medical College campus. It is very interesting one. I will show you the slides in the last part of my talk. What are the information we want to have? I mean, we need to know about the anatomical details, functional evaluation, myocardium, metabolism assessment, myocardial perfusion, myocardial viability, and risk stratification following acute myocardial infarction, and ischemic memory assessment. It is also very interesting one. So here are some images of the cardiovascular imaging. You can see here the optical coherence tomography, echocardiogram, intravascular ultrasonography. During coronary angiogram, we can have informations, I mean, not within the lumen only, we can have information outside, beyond the lumen as well. I mean, if any atherosclerotic plaque is there, their plaque composition with virtual histology, we can have idea of the plaque, whether it is vulnerable plaque or stable plaque. Coronary CT and cardiac MRI, you can see here gadolinium enhancement in case of infarction. So I think cardiac MRI also very important tools to diagnose myocardial viability. And in this era of non-invasive imaging, in terms of structure, function, and molecular basis, I mean, SPECT is the forefront and PET is beyond this modality. So these two modality can assess both ischemia and viability. I think we can have information from the cells of the myocardium. Consequence of coronary disease. After coronary stenosis, there is impaired coronary flow reserve, hypoperfusion, metabolic abnormalities, diastolic dysfunction, systolic dysfunction, STT change, and angina. So before having chest pain, patient might have this type of abnormalities. So we can assess coronary flow reserve by echocardiogram. We can assess myocardial perfusion. We can assess metabolism by echocardiogram. We can assess diastolic dysfunction and systolic dysfunction as well. So what happened after ischemia? If we can reperfuse within 20 minutes, it's completely salvageable. And if it is not possible, even within 4 hours, if we can reperfuse, there is some sorts of infarction as well as non-viable dysfunctional myocardium is there. And if there is permanent occlusion, there is scar tissue and necrotic myocardium is there. So these are the frame. I mean, after ischemic cascade, what are the pathology going on in the myocardium? We can assess in different ways of using nuclear medicine technique. Worldwide nuclear cardiology work is growing off, especially in the America, in the Australia, in the Japan, and part of Europe. You can see nuclear cardiology work is going very high. And I was in Japan for my PhD research work in nuclear cardiology, so I am very much happy to work with them. Especially in the developing country, to promote nuclear cardiology work, International Atomic Energy Agency, Vienna, they are just discussing how we can proceed, how we can promote the nuclear cardiology work in the developing world like Bangladesh. And in terms of radiation, always we have to think the radiation safety for the patient. So there are some issues, and actually IAEA also governing this kind of condition. Cardiac scintigraphy or nuclear cardiology, this includes myocardial perfusion. It can be gated or non-gated, myocardial metabolic imaging, fatty acid metabolic imaging, glucose metabolic imaging. I worked with the free fatty acid metabolism in Japan. And cardiac neuroreceptor imaging, cardiac gated full imaging. Actually, gated full imaging not usually done today because advancement of echocardiography is much more in advanced techniques. We can use the ejection, we can assess the ejection fraction and wall motion, everything very nicely. What is MPI? Myocardial perfusion imaging, it means how well blood flows to the heart muscle and how well heart muscle is pumping. This test may be done during rest and while you are on exercise. A myocardial perfusion scan uses a tiny amount of a radioactive substance. the tracer travels through the blood and absorbed by the healthy myocardial muscles on the scan. Areas where tracer has been absorbed look different from the areas don't absorb it. So after injection of radio tracer, a special type of camera is used. We call it gamma camera or PET camera. This can find radioactive energy from outside the body, and camera takes images of the heart during stress and again on rest. Here you can see the image of myocardial perfusion imaging. This is the stress image and this is the rest image. So on the stress image, there are perfusion abnormality, and on rest image, reversible. I mean the no perfusion abnormality on the rest image. That means it is ischemia. And this group of patients are suitable for revascularization. So this myocardial perfusion imaging, I think before revascularization is very, very useful for the cardiologist for the intervention, I think. What are the indications of MPI? Intermediate risk of coronary artery disease when other examinations evaluating coronary reserve yield ambiguous result like ETT or double stress echocardiography. High indices of coronary artery calcification revealed by coronary CT angiogram with contrast was abundant. Patients in whom the evaluation of ostial lesion or coronary stents yields uncertain result, as well as in patients with borderline changes in order to assess their hemodynamic significance. And myocardial bridging are revealed by coronary angiography on angio-CT whether systolic constriction of the vessel has any influence on the LV perfusion. Myocardial viability before revascularization procedure is very useful in case of renal failure where contrast use is contraindicated. So these are the common indications of MPI. And nuclear cardiology work in Bangladesh, it was initially started in NINMAS, now in the BSMM campus. It was started in 1994, and then from 2004 onwards, MPI was performed regularly and skillfully. In my Dhaka Medical College Center, where I have been working since 2010, it was started in 2007. And if you ask about the price, it cost around 7,000 taka, and in the private center like United Hospital, Apollo, or CMS, they charge about 20,000 taka. Cardiac aspect research, there are certain radioactive material we use. Microbial perfusion imaging, for the microbial perfusion imaging, 99 m technetium level tetraphosphine, and system AB, and cardiac sympathetic neuroreceptor imaging are in 123 level MIBG. It's not available in my country. And infarct imaging, now it's not doing. Actually, it can assess the size of the infarct with the help of pyrophosphate. So usually we are usually using tetraphosphine in my center for the perfusion imaging. So molecular basis of myocardial perfusion tracer, you can see here the myocyte and the perfusion tracer like thallium, which is cyclotron produced. You can ask me where it is possible. Now we can produce thallium because we have cyclotron in BSMO campus of our own from Bangladesh Atomic Commission. But maybe and tetraphosphine, they entering the cell and they represent the mitochondrial membrane integrity. So there is electrochemical gradient and entering the cell, and thallium, there is sodium potassium pump, and with the cationic flux, they entering the cell. So these two ways, perfusion tracer entering the myocardium or the within the myocyte. So there are two protocols. One is a stress protocol. A stress rest protocol. It may be 1 day or 2 days. Rest stress protocol, 1 day or 2 days protocol, and rest only imaging or only rest imaging. So different way. It depends on the choice of the patient, choice of the cardiologist. So for the stress, pharmacological stress, we are using adenosine, dobutamine, and dipyridamole. Worldwide nowadays, adenosine is most commonly used because it's very safe and short-acting. Non-pharmacological ETT and bicycle ergometer we can use, but now in my center, actually, we are using adenosine only. So there are standard preparation and some precaution for stress studies. So before going to start a stress test, we have to assess the patient. We need to take the clinical history of the patient. So in modified Bruce protocol, there is on stress, 85% of the predicted heart rate will raise, and then we should inject the isotope, and then 1 minute he will continue exercise. And 3 hours after, rest imaging is taken, and usually we use more than 2 or 3 times the isotope. Here you can see 8 millicurie, here we can use 24 millicurie. And for augmentation of this test, glycerin trinitrate can be used to pump to 10 to 20 minutes before the rest injection. And different ways we can take the images, computer, and the different kind of filtering. So the image will be smooth, and the patient position will be supine. Patient position will be definitely supine position, and left hand will be raised. Here you can see the Bruce protocol. There they are using Bruce protocol, and those patients have some sorts of pain in the knee joint. They cannot walk on the treadmill. So I think for safety and for easiest way, we can use adenosine. So this is 9 minutes protocol, 3 minute, 3 minute, and 3 minute. I mean, after 3 minutes of adenosine infusion with a dose of 1.14 milligram per kg body weight, we use tetraphosphine, and after that we continue 3 minutes, and after finishing the adenosine for 6 minutes, then 3 minutes patient will stay on the bed for recovery. We can assess the ECG change or blood pressure or heart rate. If there is any blockage or if there is extra system, we can assess that. There are certain absolute contraindications like asthmatic patients with ongoing wheezing, severe COPD patients, severe AV block, use of dipyridamole containing medications, caffeine within the last 24 hours, and low blood pressure, unstable acute myocardial infarction. In this condition, better to avoid adenosine stress test or dipyridamole stress test. The flow chart of the stress and rest protocol, you can see here stress injection, and after 30 to 60 minutes it will go it will distribute in the myocardium, and we can take the SPECT image. It will take 20 minutes. Then after 3 hours of injection of the stress injection, after 3 hours patient will stay in a calm and quiet room, and then we will inject again, and after 30 to 60 minutes waiting period, we'll take image on the gamma camera. This is the gamma camera. Patient will stay, will lie down in the bed, and here you can see the dual-headed camera, one camera, and that is another camera. And recently we have got another machine, SPECT CT. So that is CT gantry machine, CT gantry, and this is the dual-headed camera. With the help of this machine, we can have the coronary CT angiogram as well. So simultaneously, we'll get the data of nuclear cardiology technique as well as the CT information. So here you can see one diagrammatic representation of the patient lying down, and then the photon is liberating from the patient body, and different images are taken in different angle of rotation. So we'll divide the heart from apex to base. We call it short axis slices from apex to base, and then we can slice it from the medial to lateral. I mean the vertical long axis slice from medial to lateral wall, and another slice from inferior to anterior wall. We call it horizontal long axis. So different wall, I mean lateral wall, septal wall, and right ventricular wall and apex. Different wall we can assess with this type of section. So in a polar map, I mean the territory, we call it bull's eye or polar map, and this polar plot is very much comparable with the echocardiogram. I mean different territory of the artery, LAD, RCA, and LCX, and their distribution of pressure we can categorize in this way. I mean on a 17 segment model, I mean short axis slices we can divide from apex and at the mid region and the basal segment. Here is 16 slides, and for the 17 slides, 17 numbered, I mean, we will take the vertical longest slice for this another segment. And the distribution of the radio tracer, we can categorize normal, I mean 0, and mildly reduced 1, markedly reduced 3, and absent tracer uptake, it will be 4. So in this segment, we can assess the distribution of the radio tracer. The gated MPI, I mean the systolic and diastolic information from one R to another R interval, there is the left ventricular curve. From this kind of software, we can have the information of the left ventricular wall motion abnormality, as well as the wall thickness and systolic and diastolic volume and ejection fraction as well. And this perfusion imaging is very much comparable with the left ventriculogram. You can see here on the left ventriculogram, the ejection fraction 59%, and on the spectrum is 58%. It's very much comparable. How we can interpret the image? Normal, I mean both the stress and rest image perfusion will be normal. Reversible defect, I mean on the stress image there is defect, on the rest image no defect, this is ischemia. There's the fixed defect, I mean no change in the stress and rest image. In both type of image there is a defect. And fixed defect with an area of reversible defect, I mean infarction plus ischemia. This group of patient is very bad patient. And another group, reverse redistribution. I mean on stress there is abnormality, but on rest there is no abnormality. In case of old MI, a rare condition, very rare condition, we can have such kind of images. How we can quantify the image, how weak the lesion is. We can categorize it is small, it is medium, or it is large. If it is a small, 1 to 2 segmental involvement. And if it is medium, 3 to 4 segment, I mean out of segment in segment. If it is large, more than 5 segments will be involved. And how much myocardium involved? Again, we can categorize estimated score on this way. I mean, depending on the radio tracer accumulation, and divided by 68. 68 means if there is absent tracer concentration, I mean 4 into 17, it will be 68. Into multiple by 100, then percent of myocardium we can assess. How much myocardium is involved, we can assess. Here is the images. You can see there is normal on the stress image, and the rest image there is no perfusion abnormality, it is normal. And there is reversible perfusion defect. You can see on the stress there is perfusion abnormality, on the rest there is no abnormality, so this is ischemia. And fixed perfusion abnormality, you can see here on the stress and rest, the size and intensity of the perfusion abnormality all the same, so we call it infarction and scar. Not only that, on the gated image, I mean the movement of the myocardium, we can clearly observe the wall motion abnormality, left ventricular cavity, and muscle thickness, everything with this kind of software. So this is very interesting. And there is transient dilatation of the left ventricular cavity. It is very important to know that in case of hypertrophy, sometimes subendocardial layer ischemia representing with this type of findings. I mean, on rest there is no dilatation, but on stress, if there is transient dilatation, it is significant. Here, you must appreciate this is a normal myocardial perfusion scan. On stress, you can see no perfusion abnormality. On rest, there is no perfusion abnormality in both short axis, vertical long axis, and horizontal long axis slice. So there is no perfusion abnormality. This is a normal patient data. And this image, you can see the defect in the inferior wall, and on the rest image there is no perfusion abnormality, and the inferior wall there is perfusion abnormality. Here it is normal. So this is ischemia in the inferior wall and apical region. And another slide, you can see here the infarction plus ischemia. I mean, in the septal wall, you can see the lesion is bigger, but here's partial recovery. and the inferior wall also there is defect. Here is partial recovery. So here is infarction and ischemia is there, and the muscle thinning of the apex and inferior wall. So these three examples can explain you the infarction and ischemia, how intense, and the cavity dilatation and their ultimate outcome you can assess with this kind of images. So nowadays we always try to do the gated MPI. Gated MPI always appreciable because we can assess the regional mobility and the systolic and diastolic volume, ejection fraction, and severity of contraction abnormality, diastolic function, as well as systolic function. So always we are appreciating the gated MPI. So the take-home message is proper interpretation of the microbial perfusion scintigraphy using the SPEC method not only enables the diagnosis of the significant stress ischemia, it provides valuable prognostic information determining the choice of treatment. I mean, optimal pharmacological therapy, I mean medication or invasive treatment to be provided to the patients, including those with borderline changes revealed by CT angio or with high indices of coronary artery calcification. The sensitivity, I mean the MPI sensitivity depending on the timing. If it can be done within 6 hours of onset of MI, it is AMI, it will be 100% sensitive. After 24 hours, it will be 75% sensitive. High sensitivity is a result of peri-infarction ischemia contributing to the size of the defect. If it is transmural infarct, 85 to 100% sensitive. If it is non-transmural, it will be 50%. If it is anterior wall lesion, it will be 100% sensitive. If it is inferior, it is 85% sensitive. And sensitivity is decreasing in old infarction due to small size of the infarct, scar retraction with time, overlaying normal tissue obscuring infarction, and systemically not statistically different from the thallium. So in our country, better to go with the systemically. Sensitivity increases from single to multivessel disease. I mean, in single vessel disease, it will be 73% sensitive. In multivessel disease, sensitivity definitely would be higher. Sensitivity definitely on the LAD territory would be higher than that of the RC territory and LCX territory. And if suboptimal exercise decrease its sensitivity, I mean by 50%. Nuclear technique is very powerful to assess the coronary events. So you can see here the ischemic event depending on the extent of ischemia. So I think for follow-up of the patient, it can be a nice tool. So main goal, what is the target of our study and how we can assess the high risk and low risk group. To identify patients with high risk of cardiac death or non-fatal myocardial infarction so that appropriate measures can be taken promptly. That is one goal. Another thing is patients with low risk of cardiac event can be spared unnecessary invasive procedures. What are the high-risk groups? Reversible defects with the infarct zone, that is one. Number two, multiple vessel disease, a large non-reversible defect corresponding to a large infarct size and cumulative zone of non-viability. I think old and new infarction, because in this category, there will be arrhythmic focus. Transient left ventricular cavity dilatation from stress to rest imaging, and increased lung and heart ratio. I mean, with the thallium, if we use thallium, then it will be significant. And resting ejection fraction, if less than 40% on gated SPEC, that patient will be very much risky. There is a study in Japan. When I was working in Fujita Health University, we just compared coronary CT angiogram, cardiac MPI, and cardiac CT angiogram with MPI. And we observed that sensitivity, specificity, and accuracy both are increasing if we use these two modalities, coronary CT angiogram and MPI, as well as negative predictive value also, you must appreciate 92% if we use these two categories. So if there is a chance, we can use CT angiogram as well as MPI to assess the patient's high risk, low risk, or intermediate risk group. This patient had heart failure in 2016. You can see ejection fraction was 13% and diastolic volume was 350 ml, I mean large LV cavity. And after 1 year, you can see the improvement after medication. So improvement assessment, it is very important. So you can use myocardial perfusion scan. So this is about microbial perfusion scan. Beyond this, there are some nuclear cardiology techniques I used in Japan as well as worldwide they are using. Especially you can see the metabolic imaging. What we are discussing today before starting my talk, we are thinking to evaluate the microbial viability or to arrange another session for assessing microbial viability. So in my country, fluorinating FDG PET is useful for PET scan. In Japan, I used BMIPP, I mean one free fatty acid analog that is cyclotron produced on isotope. And sympathetic neurotransmission imaging is possible within iodine 123 level MIBG scan. Another interesting thing is if we want to use, I mean 99M technician annexing, it is possible. It is not so expensive one to assess the apoptosis, vascular plaque, and angiogenesis. And gene expression also possible. In Japan, they are using these things. And lastly, anti-tenascin C monoclonal antibody for myocardial infarction, atherosclerosis, myocarditis, and certain cardiomyopathy assessment is possible. So I would like to share with some slides about myocardial viability. I mean, myocardial viability is possible to assess. Dobutamine stress echocardiography is helpful. Conventional SPECT perfusion imaging is helpful. Positron emission tomography and recently magnetic resonance MRI. But what is the gold standard? I believe PET is the gold standard for the myocardial viability assessment, and it is very nice to assess the myocardial viability. On myocardial viability assessment, there are two terms you can hear. One is mass defect and another is mismatch defect. Among regions with resting hypoperfusion, a concordant decrease in both perfusion and metabolism, I think it is called mass pattern, and it represents scarred or non-viable myocardium. And a discordant increase in FDG uptake compared with the perfusion tracer, I mean mismatch pattern. So if it is mismatched, then this group of patient is suitable for revascularization. And application of such patterns in the clinical setting has resulted in positive and negative predictive accuracies of about 78 to 92% range. So it is very appreciating one. So this is the PET image. You can see accumulation of the glucose, fluorinating FDG glucose in the heart. So in my center, routinely we are using cardiac PET using the fluorinating FDG, and the protocol is glucose loading protocol. So we use insulin along with oral glucose so that glucose can enter the myocardium, because you know well, heart muscle usually taking its nutrition from free fatty acids. So we have to forcefully introduce the myocardium, introduce the glucose in the myocardium. I mean, the PET camera, looks like a CT machine, but here there is two gantry. One is CT, another is PET in my office. This machine started operation on May 2018. And this the tracer, you can see everywhere, one radio tracer, another kit. So there is the tracer fluorinating, and FDG is the glucose analog. We can use for the cardiac, we can use for the oncology perspective, we can use for the infection assessment. So different ways we can use this PET camera. Here is a cute example of hibernation of the myocardium. You can see on the thelium, there is no perfusion in this region, but still there is a hope. If we use the fluorinating FDG, you can see there is metabolism. So this is the cute example of hibernating myocardium. So after revascularization, this group of patients will be improving. On the perfusion and metabolism, there is a severe mass pattern you can see on the perfusion abnormality, and there is metabolic abnormality. And here multimodal match pattern, and the mismatch on the perfusion abnormality here. And you can see on the metabolic imaging there is good metabolism. So, and another thing is reverse mismatch is also possible here very rarely. And in case of old MI or like MPI, this category is very rare. We should keep in mind there should have reverse mismatch also. So this image firstly done in my center in August 2018. This is the first case of cardiac gated PET. Usually before this year, worldwide only non-gated PET was used, but this Philips machine installed here in Dhaka Medical College campus, they claim that this is the first software they are using, and gated PET is possible with this kind of machine. Now I would like to share with you all the 3 clinical scenario recently done in my center, the cardiac SPECT and PET. This patient cardiac MPI, female patient of 52 years old, diabetic, hypertensive, and unstable angina was there. Ejection fraction was 65%, no regional global or global wall mission abnormality. And on coronary angiogram, you can select main trunk lesion, LAD. There was ostial lesion in mild form, and LCX also non-dominant, and ostial lesion was there. On RCA, actually free of disease. And on the angiogram, you can see the territory. But what happened with MPI? You can see no perfusion abnormality. No perfusion abnormality. It's a good perfusion, and the wall is thickening of the wall. So on microtubule perfusion imaging, with the help of technetium leveled maybe marked concentric hypertrophy of the left ventricle, we call it hypertensive heart, and normal microtubule perfusion. So we could exclude any perfusion abnormality. So that patient only medication was enough for that patient. This patient cardiac gated SPECT. You can see gated SPECT, and we could assess the wall motion. Left ventricular cavity was not dilated. As a good contraction, you can see here both stress and rest. I mean both images you can see, and good LV systolic function, 78%, and RV cavity was not visualized on the image. Actually, RV cavity is dilated, and when a heart failure is there, then we can assess we can see the right ventricle also. Now, case number 2, male patient having 56 years, had a microtubular infarction on the anterior wall, had a LVF, and diabetic dyslipidemic patient. On echocardiogram, ejection fraction is very low, 32%, and you can see on the coronary angiogram, triple vessel disease was there. Left main trunk, LAD lesion, LCX lesion, and RC lesion also there. And then we did MPI and PET. You can see on the MPI, the microtubule perfusion scan showing different territory, and there was perfusion abnormality in the multivessel disease form. But on the PET image, there is a good microtubule accumulation of the glucose. So very little area of abnormality on the PET image. In this image, on the bull's eye map, you can see clearly. Here is the MPI image. There is a defect. There is a defect, you can see, and about 24% of the LV myocardium was involved. And on the PET image, approximately only 8% of the myocardium involved. So there is a mismatch, you can see. There is a mismatch. Only 8% on the PET image. I mean, the rest part of the myocardium was viable. The gated 3D volumetric data showed on the PET image, 35% ejection fraction is still very low, and global dyskinesia and akinetic apex, apical, septal, and anterior wall thinning, marked LV cavity dilatation. RV cavity is not visualized in the image. So that was a good candidate for revascularization, and accordingly on the report, just we gave report in that way. Large perfusion and metabolism mismatch defect in the anteroseptal wall and apex, signifying ischemia and suitable for revascularization. Small-sized, mild perfusion metabolism mismatch defect in the apical lateral wall involving LCX territory, also suitable for revascularization, and medium-sized perfusion abnormality, and it was also suitable for revascularization. And normal perfusion and metabolism in the lateral wall, markedly dilated LV cavity with global hypokinesia and akinetic capex, and moderate LV systolic dysfunction. That was our report. And the third case, in a perfusion metabolism mass pattern, how it looks like. This patient, male patient, 62 years old, had acute myocardial infarction and dyspnea. Echo findings was ISD with regional wall motion abnormality, dilated LV cavity, moderate LV systolic dysfunction, 35 to 40%. On coronary angiogram, there is triple vessel disease. You can see severe disease in the LAD, LCX, and RCA territory, where RCA was dominant and totally occluded. So in this case, we used perfusion and metabolism imaging. On perfusion imaging, you can see there are certain fixed defect in the different territory, and on the metabolism also, you can see almost absent erythrocyte concentration. Very large lesion was there. In this bullseye map, you can see clearly on the perfusion scan there is a lesion in the LAD, RCA, and LCX territory. Triple vessel disease, and the lesion also clearly depicted on the PET imaging. Almost same type of lesion. It was a fixed lesion. It is a fixed lesion. Here the microbial involvement was 47%. Here 58% of microbiome was involved. So almost fixed type of lesion. And on the gated image, marked septal wall dyskinesia, hypokinetic inferior lateral and anterior wall, and LV cavity was dilated. Ejection fraction was only 22%. So in this patient, I think this patient is not suitable candidate for revascularization. Again, image for the patient on PET image, you can see LV cavity at the dilatation, and right ventricle you can see on the image, right ventricle. So what we wrote on the report: large size severe perfusion metabolism mass defect in the lateral wall, LCX territory, with slight mismatch, signifying large area of peri-infarct ischemia, and not suitable for revascularization. Another medium-sized severe perfusion metabolism mass defect in the infraseptal wall, RCA territory, also not suitable for revascularization. And perfusion metabolism mass defect in the apex, suggesting non-viable myocardium, and severe perfusion metabolism mismatch defect also noted in the LAD territory, suggesting ischemia, and maybe suitable for revascularization at little chance, and marked dilatation of the LV cavity with global hypokinesia and septal dyskinesia. Severe LV systolic dysfunction was there, 22% ejection fraction. So with these three images, you could clearly observe that how perfusion and metabolism imaging can help the cardiologist or intervention cardiologist for revascularization. Which patient we should not go for revascularization. And for better depiction, both images we can fuse. Nowadays there is software in our office. We can use these two data. We can fuse. This is the FDG image. PET. This is the perfusion image. Here the perfusion defect is large than that of the metabolic abnormality. And which part is viable? This color coding can give you the information. Only this part is only viable. So we can fuse these two images, and clearly we can assess the viable zone of the myocardium. So key issues of nuclear cardiology promotion. Professionals need to be useful and deliver quality work. Professionals should keep up to date and current knowledge, and participate in cardiology meetings and clinical discussions, explore opportunities to participate in regional scientific meetings and deliver talks, build useful and friendly relationship with the referring physician. Always we try to maintain these things, and know the strength and no weakness of the nuclear cardiology work. Definitely there are some weakness of nuclear cardiology. Every modalities there should have some weaknesses. Explore scientific cooperation and others, specialists and institutions, and explore opportunity to the research and publish, if possible, help healthcare providers, I mean public and private, with the protocols. So these are the key issues to promote the nuclear cardiology work. And my dear colleagues and my teachers and ladies and gentlemen, in conclusion, I would like to say, from its humble beginning, nuclear cardiology has entered into the new era of molecular cardiology, as I showed in the pictures. I mean, it has pivotal role for the assessment of the myocardial ischemia and viability, risk stratification following acute myocardial infarction, and prognostic information following coronary intervention. The use of attenuation correction in conjunction with fusion imaging may lead to a unique diagnostic tool for the cardiovascular imaging. With the advancement of the technique, it can be assumed that nuclear cardiology will remain in the forefront of the assessment of cardiovascular function. So here is one picture of my teacher, my supervisor in Physical Health University, where I was there for 4 years. And I was very much happy to work with them. And my research work was presented in the SNM meeting, Society of Nuclear Medicine meeting. I mean, it is the largest forum in the world of the nuclear medicine group. And he's Professor Dilsiajan. Professor Dilsiajan is the nuclear cardiology, pioneer of the nuclear cardiology work in the United States. He has several books. And I am deeply honored today to be here to announce that my research work also been published in a textbook. It was published in 2000, just 2 years ago, in from CRC Press, an Atlas of Clinical Nuclear Medicine, and I was the author, and I'm very much lucky enough to put my research work in this book. And there are several publications. You can go through net on the PubMed. You can find my research work. Just several research work published here, and having high impact factor journal. And lastly, that was the great teaching from my university, Physical Health University, Japan. I mean, if we want to have good things, we need patience, and we must be grateful for that. So thank you very much for your kind attention. And I think in this Corona pandemic, we must stay safe, and God bless us for our healthy life. Thank you all.
Thank you so much, Professor Shankar. Thank you. I think most elaborate discussion regarding the MPI and PET also.
Hello.
But it is not.
Hello.
Hello.
Shankar, you take off the headphone. Shankar,
Hello. Hello.
Shankar, you take off the headphone, please.
Hello, স্যার আমি শুনতে পাচ্ছি না। হ্যালো
সৌরভ, ওকে বলো ডিটাচ করে ফেলতে, শুধু ডিভাইস।
হ্যাঁ স্যার, আমি ফোন দিচ্ছি স্যার, ফোন দিচ্ছি।
তাহলে ভালো হবে, এইটার জন্য প্রবলেম হচ্ছে। For the audience, the last case he was showing the severe defect, ejection fraction 22%. That was my case actually. The only thing, given the situation, that can be done actually giving intense medicine. I am planning. Situation suggests if you can open up to the first septal artery in that patient, the basal territory IVS have some improvement.
আমি শুনতে পাচ্ছি না, কি করব?
শঙ্কর, শুনতে পাচ্ছ এখন?
Sir, Wadud sir?
হ্যাঁ।
Do you hear me, sir?
If that I'm stabilizing.
You can discuss, sir. You should first comment, sir, Wadud sir. Then we go to the Mishkat sir, Mr. Gafur, Ajoy, and Enoch here. Sir, Wadud sir, please.
I'm planning in that patient to revascularize up to first septal if that is possible. And that will improve the basal septal area. And that is also supplying part of the inferior valve where some of the viable tissue is present. Actually, RCA territory cannot be revascular at all. That's totally gone. Absolutely horrible. And at present, I'm keeping the patient on intensive medicine. And thanks to Shankar, recently I have done some patients where among the different vessels, I've been able to limit the level of intervention depending on the presence of viable tissue. And leaving aside the area where though there is very nice looking identity, because that lesion won't intervention will not any at all. Rather, it will increase the cost of the procedure. And
Hello.
Shankar,
হ্যালো হ্যাঁ শোনা যাচ্ছে শঙ্কর স্যার শোনা যাচ্ছে
শঙ্কর তোমার ডিভাইসটা পুরোপুরি খুলে
Hello.
তুমি সরাসরি ইয়ে থেকে শোনো।
শুভ্র শুভ্র শুনছিস নি
স্যার ওনার ডিভাইসে
স্যার শুনতে পাচ্ছি স্যার।
শুভ্র তুমি শঙ্কর স্যারকে বলো যে ওনার হেডফোন বন্ধ করে দিতে, ওপেন করে ফেলতে, হেডফোন পাওয়া যাচ্ছে না।
স্যার ওনার ডিভাইসে প্রবলেম আছে স্যার, এই জন্যই স্যার বলছি, ওই জন্য হেডফোন চেঞ্জ করেছে, হেডফোন চেঞ্জ করেছে স্যার।
হেডফোন দরকার নাই তো, হেডফোন দরকার নাই তো
স্যার ওনার ডিভাইসে স্যার একটু প্রবলেম স্যার, ওনার ডিভাইসে এমনি শোনা যায় না স্যার, কালকে ট্রায়াল দিয়েছিলাম স্যার।
মোবাইল নিয়ে করো। হ্যাঁ আছে,
ঠিক আছে।
Mishka sir, do you hear me, sir?
Yes, I can.
Lots of question here because lots of raise hand. Mishka sir, please comment.
আমাদের এখানে মেশকাত কোনো person who
Mishka sir, বলেন sir.
interested in nuclear cardiology, viability issue and other things. And he has been
Yes, sir.
use of abdominal stress echo and other assessment tool before revascularization. He is actually a champion of that. And what is his opinion of the whole thing? Mishkat bhai, you
Okay, thank you. Hello. Actually, the day when the BSME University was started in 1999 is the same year when the Institute of So in the year of 1999, when the BSMU started, in the same year, the Institute of Nuclear Medicine, they also started their journey on cardiac imaging. So from the very beginning of their journey, I had the opportunity to be with them, and all the pioneer in this field in Bangladesh, I had the opportunity to be with them. But today I was really, it was a fascinating lecture. I was really amazed with this lecture. Because as a person who is not really a cardiologist, but working with the nuclear imaging and having the in-depth idea about the cardiac aspect was relatively rare in my experience from the nuclear guys. So Professor Shankar has really impressed me, and he has also probably given us the hope that now we can trust the nuclear guys. This is number 1 point. Number 2 point, in the earlier days, when we used to do the stress echocardiogram with dobutamine stress echo and with SPECT nuclear imaging, both these tests were relatively less sensitive and the specificity was relatively less. Now we have the exercise stress echo in BSMMU, and also at the same time, we do have the PET in the nuclear sector. So PET is definitely even superior than the exercise stress echo in terms of inducible myocardial ischemia, and definitely in terms of viability assessment. So we talked a lot about the STITCH study. STITCH study was a study which was showing that if we do revascularization in patient with or without viability assessment, meaning that if we do revascularization in patient who has got viability and who do not have viability, their mortality was same. So this is the point where people started thinking that the knowledge about the viability is not that important. But please remember, it was the time when we had only the stress echo in terms of dobutamine stress echo, and we had the SPECT MPI. But now we have MRI and we have the PET scanning. Both these tests are so excellent and almost have near to 100% sensitivity in detecting the viability. So things has changed. And now we now have to think about rethinking about the stage trial, because probably in the patient who were included in the stage trial and was marked as non-viable, probably those were the patient had really the viability. And another beauty of the PET scan is generally we think when a patient in echocardiography do have their wall thickness of less than 5 millimeters, they do not have the viability. But with PET scan, it was also shown that even in those thin portion of the myocardial segment, there are some viability. So PET is an excellent test in terms of detecting the viability. And I'm really impressed with Professor Shankar that he has landed the whole thing in reality. We actually have at a time the technology in our hand. We have some trained person with us, but in reality we cannot at a times get the real things. Now I'm really hopeful with his presentation that we'll be able to utilize these modalities of imaging. And I also want to make a comment about the utility of the imaging modality as a whole. It is so delicate, and at times it is so frustrating because in 80 to 90% cases they can detect it, and in 10 to 15% it also can really miss it. Unlike coronary angiogram, which detects 100% of the coronary lesion. So people are more inclined in doing the coronary angiogram directly because it shows the 100% lesion for accuracy. But in between this period, we really have to develop our skill in imaging technique to apply those knowledge in terms of whether which patient is going for angiogram, which patient is going for intervention, how we are going to use those tools as risk factor stratification. All this knowledge are generally lacking because we really did not have much people doing this work. People with nuclear medicine like Shankar, Professor Shankar, if he does this work, continue to do this work, and it is so important that now we have frequent meeting with the nuclear guys, and that is probably Professor Shankar also will be eager to be with us to have more and more interaction. Without practice, actually, all this theoretical knowledge will again become theory. And in practice, generally, we do not prescribe so much of stress echoes and the nuclear imaging. But I think now we are in a situation, especially if IPD continues their program like this, then we'll be involved more more in doing imaging, and we'll know more about knowing how to utilize those imaging techniques. Little bit difficult, but once we acquire those knowledge, those different modalities, their advantage and disadvantage, their limitation and their pitfalls, then probably we'll become better physician. And in recent time, there is a new term which is known as precision test. Not really when we say sensitivity of certain tests and the specificity of certain tests, when we allocate risk factor in certain population, it does not really means that what the meaning of all these tests for particular patient. For particular patient, we need to really precisely should be able to say actually which test is best test for him. So we need lot more drilling and lot more exercise in terms of imaging, so that we can use those technology in our cardiology practice. That is what my realization after today's lecture.
Thank you. Then Dr. Shubro, do you hear me?
Sir, yes, sir. Sir.
Please put your question, please.
Sir, okay. Actually, thank you, Shankar sir, for his nice presentation. And I have got lots of questions. First of all, sir has said that in case of inferior wall, it has got less sensitivity, MPI. And why so? And how sir is going to differentiate between the hibernating stunted or stunted myocardium by MPI? Which question is usually asked in the examinations. And my third question is whether PET has got any role in detecting INOCA, like ischemia in non-obstructive coronary artery disease. We usually found normal coronary arteries in some patients, and whether a PET has got any role in this. Okay, sir. Thank you.
Dr. Shankar, do you hear me? Professor Shankar, do you hear me? Please unmute. Please unmute.
Sir?
Professor Shankar, please unmute.
Yes, sir.
He had 3 questions. Please unmute.
Sir, yes, thank you. Thank you, sir, for a nice question. And actually for the inferior wall, myocardial ischemia assessment, and as he asked about the hibernating myocardium, better to go with perfusion scan and PET, as I showed one slide, but only with MPI, still it is possible, because the camera, we are using the camera is more on the anterior wall and lateral wall.
Professor Shankar, do you hear me?
Hello, sir.
আপনার আরেকটা ডিভাইস বন্ধ করেন, আপনার দুইটা ডিভাইস, একটা ডিভাইস বন্ধ করতে হবে।
শঙ্কর স্যার, আপনি আপনার ল্যাপটপ থেকে একটু লিভ করবেন, যদি আপনি মোবাইল থেকে ইউজ করেন।
ল্যাপটপটা বন্ধ করে দেন,
ল্যাপটপ থেকে লিভ করবেন স্যার, প্লিজ।
ল্যাপটপটা বন্ধ করে দিচ্ছি।
বন্ধ করে দেন, হ্যাঁ, অন্য রুমে নিয়ে যান, বন্ধ করে দেন কাকু দিয়ে, আপনার ছেলেকে দিয়ে।
ওকে,
ঠিক আছে, ওকে, নাইস, ওকে।
এখন ঠিক আছে, এখন স্যার শোনা যাচ্ছে আমাকে? স্যার শোনা যাচ্ছে?
ক্লিয়ার।
আচ্ছা স্যার, যেটা আমি বলছিলাম যে ইনফেরিয়র অফ দ্য মায়োকার্ডিয়াম আমরা ভালো দেখতে পাই না এই কারণে যে যেটা হলো ক্যামেরা থেকে দূরে থাকে একটা জিনিস, সেটা হলো একটা জিনিস যে আমরা যখন ক্যামেরা, when you are using the camera rotating from the anterior wall, lateral wall, even in the inferior wall as well, but the myocardium of the inferior wall is far away from the camera. That's why if there is infarction or ischemia in the inferior wall, the sensitivity is low, always is becoming low. But the PET sensitivity not varying so much, because the strength of the molecule using on the PET, the strength of the isotope, energy of the isotope is much more. So in case of doubt of the inferior wall ischemia or hibernation or infarction, better to go with the perfusion scan as well as the PET, I believe. And the second question, how we can overcome, he wanted to know how we can overcome. Actually, on the inferior wall, there are a lot of obstacles. There is stomach is there.
Diaphragm, stomach, duto. Both.
Yes, diaphragm. The stomach and the diaphragm. That's why during a stress injection, always we try to explain the patient, please keep fast, because in the fasting state, stomach will not go afterwards. That's why the technetium, usually using on the MPI scan, the technetium will secrete in the stomach, so it will interfere the inferior wall uptake. That's why absolutely patient will keep fast before injection of the PET, MPI tracer. That is one thing we can overcome. And as I mentioned, that is the common limitation of the MPI to assess the inferior wall. And in that case, better to go with PET. That is my suggestion. That would be more appropriate. MPI scan, and if there is any doubt to evaluate inferior wall, better to go for PET. Thank you so much.
One thing is that my observation is that when the patient have triple vessel disease, sometimes it can be deceptive, because every wall is taking less amount of tracer.
Yes.
Ischemic. So you cannot actually compare between one wall and the other. And sometimes you may find the MPI is quite all right, apparently normal, but it's not. And in that case, PET is better. And also,
yes,
the wall, that is so. The third case, sometimes MPI will show there is no reversible ischemia, but PET will show, as we have shown, that
yes,
is viable tissue. These are hibernating tissue. And hibernating actual identification, you have to go for PET.
Yes, sir.
And so,
thank you, sir. Professor Tuhinok, madam, do you hear me?
they will be better assessed by PET.
Yes, sir.
Thank you.
So sir, I want to include one thing in terms of cost of the test. MPI cost is only 7,000, and for PET in the government section, still we are taking 30,000 taka. But we have our own cyclotron. That's why we no need to purchase from United Hospital next time. That's why our Atomic Energy Commission also thinking to reduce the cost. In that case, if we fix it by 20,000, then I think MPI and PET both should be done before revascularization. And as I showed in my 3 cases, for better assessment, I believe confirm for better assessment, better to go with MPI as well as PET. No need to go for stress and rest. Only rest MPI is enough, and rest MPI with PET. I think that would be most suitable modality of imaging.
Thank you. Thank you, Professor Tuhinok.
Okay. Thank you for giving me the opportunity. I'm really impressed by Professor Shankar's lecture. It's a brilliant lecture. I practiced nuclear cardiology till 2004. I was consultant nuclear cardiology till 2004. After coming here, I'm confined to echocardiography, but his lecture reminded me many of our previous work. And especially I'm enlightened by his work about the metabolic perfusion mismatch. That's the gold standard, PET imaging. So I'm really impressed that at Bangladesh, PET is going on, and it is the gold standard for viability assessment. Regarding cost, yes, PET is expensive. So when we do MP imaging, I'm really, actually, to see some of the report, I'm frustrated that when assessing viability tests with MPA imaging using tetraphosphate, like my view, they're using the stress rest protocol. But stress rest protocol is not ideal for viability assessment. It should be rest redistribution or rest reinjection imaging. And there should be quantitative uptake analysis of the tracer. Whether it is my view, whether it is system, maybe there should be quantitative uptake analysis. But nobody is doing that. And even in severe LV dysfunction, the report is going on that they did the stress rest imaging. But I don't think that they can give the patient, they can put the patient under stress. It should be rest imaging. So I want Professor Shankar to highlight about this protocol.
Yes, madam, you are very right. You are very right, because for, as I mentioned, for viability assessment, dobutamine stress echocardiography on modality SPECT, I mean tetraphosphine, or maybe that is also suitable for viability assessment, because these stress are going inside the myocardium, I mean in the myocyte. As I mentioned, mitochondrial membrane integrity we can assess. That's why that is also reflecting the viability. But the gold standard is 1418 FDG. That is worldwide recognized. That's why I no need to go for a stress and rest imaging, because sometimes it is risky also. Because you know well, in Dhaka Medical College premises, Professor Wadud Chowdhury sir just encouraged me to work with him in that way. Dr. Shankar, you can work here in my lab, no problem, because I faced one problem. One patient during stress MPI in my center had LVF. And that patient just traveling to emergency to CCU, it passed a long time. I could miss the patient. And fortunately, I could save the patient with the kind help and kind cooperation of Professor Wadud Chowdhury. And from that day, I thought only rest MPI and gated PET is good enough. Good enough. So, madam, you are very right. You are very right. I think we should adhere with this protocol: rest MPI and PET, because with the help of rubidium, we could assess perfusion also. I mean, rubidium is PET tracer, but that is very, very expensive. Half-life is very short, only 20 seconds. That's why that is not possible in my country as well as in the other countries also. They don't use that. So for perfusion assessment, tetraphosphine, it is very cost effective, only 3,000 taka, and for the PET, only the 30,000 taka now we are charging. So these two modalities can explain everything to you, I think. Thank you so much.
Can I add something?
Thank you.
Dr. Ajoy, please comment. Dr. Ajoy.
The cardiologist, I have two issues. Actually, detection of inducible ischemia, that is one issue, and detection of myocardial viability, that is another issue. And you frequently see the report of fixed defect in MPI. Actually, fixed defect in MPI, there is gray zone. At least 50 to 70% of fixed defects have viability as proved by PET study. So we are cardiologists, we do not fool about the fixed defect in report that these are not viable. But fixed report in PET, around 50 to 70% is viable, which is detected by PET. So this is very important information. Another thing is actually we are cardiologists doing, we asking for NPI for two purposes. One is in multivessel disease to identify the which lesion is culprit. And another is post-MI patient in infarct-related artery. We want, if we want to revascularize this infarct-related artery in this area, whether the infarct myocardium with peri-infarct ischemia present or not. I mean, that is the mismatch, flow, metabolism. In that sense, PET must need it. So if we ask for viability test, so PET must be included in this study. Without PET, it is not possible to see the viability in nuclear study. Compared to MRI, we can do viability test. I mean, post-MI patient, within 15 to 20 minutes, we can do only see the viability. But if we want to localize the culprit lesion, then we have to stress, like stress MPI, we have to stress MRI. That is another thing. So we do not confuse with stress MPI and with viability imaging by PET. So these are the two issues. Am I right, Mr. Shankar?
Actually, yes, your thinking is good. I think for MRI, it takes long time, right? It takes long time. I observed in Japan for cardiac MRI, it took long time. For the SPECT imaging, 15 to 20 minutes, usually acquisition time. For the stress and rest, another 15 to 20 minutes. But for MRI, it took around 45 to 1 hour. It took actually a long time.
Viability, only for viability assessment, 20 minutes is sufficient. If you inject gadolinium before putting the patient in gantry, if you put the gadolinium before putting the gantry, you can do easily within 20 minutes.
Yes. I agree. They, in Japan, actually, they did cardiac MRI basically for the exclusion of cardiac sarcoidosis patient and ischemic cardiomyopathy patient, dilated cardiomyopathy patient. Sometimes they use that, but mostly they used for the cardiac sarcoidosis patients. I observed that. And you are very right. If we use gadolinium prior to enter the patient in the gantry, I think shorter time would be enough. So in that case, cardiac MRI would be alternative option to check the viability. I think it's right.
Dr. Nusrat Gafur, do you hear me? Please unmute. Yeah.
Thank you. Respected chairman, panelists, and my dear audience, Assalamu alaikum. Thank you very much giving me the opportunity to talk in such a big platform. It's a very nice presentation by Professor Shankar. Especially, I have very less idea about nuclear medicine and related to cardiac imaging. Everything already discussed. I add a small few points. One, actually, cardiac imaging is a very big area where cardiologists, radiologists, nuclear imaging specialists all work together, and the ultimate goal is maximum benefit for the patient. So every modality has some good thing, some limitation. And this is the high time to work together actually.
Yes, yes,
And
yes.
I want to say 2 points regarding cardiologists know about the viability or ischemia. And viability is one thing and ischemia is different thing. And both have positive effect, cardiac MR and nuclear medicine. And it is important for cardiologists when there is triple vessel disease, which vessel is culprit, already Ajay said. And because they get sometimes confused which one they want to put the stent or which one they want to put the graft. So in that case, if we think ischemia, penumbra, so nuclear medicine sometimes would help, but sometimes nuclear medicine needs more time, 1 or 2 days. And if I think about only viability, so SPECT has less, but PET is gold standard. In that case, MRI sometimes come first. They take less time only for viability and give very quick decision to surgeon or cardiologist. They go to the operation theater or in the intervention table. So I think it's a very good discussion, and with time we will get experienced and modality get more expertise develop, and cardiologists also used to know which modality they want get help from, whether it is cardiac imaging from cardiac MRI or cardiac CT or nuclear medicine. It will take time, but it's a very good thing that we are all discussing and sharing our experience, and also which one is good. And ultimately, our goal is maximum benefit for our patient. Thank you very much.
Thank you. Thank you. Dr. Arifur Sajal, do you hear me? Dr. Arifur Sajal.
Sir.
Yes. Yeah.
So thank you, sir. This is an excellent talk. And the thing is that how we can refer a patient. What will be the approach? Whether we should directly refer to sir or there is any easy way so that patient can reach this benefit. Shankar sir.
My question also, Dr. Shankar sir. Dr. Shankar? Oh, Shankar,
Yes.
do you hear me?
Yes, yes, I can hear you, sir. So,
MPI PET, what can do the referral physician? How easily get the patient referred to the Dhaka Medical or Bangabandhu BSMU center?
Is there any focal person so that we can help?
Yes.
Get the help.
Yes. I think just you can write your requirement. I think advise the patient for MPI and PET. You should write down REST MPI and PET study, and they can contact with our office directly, and you can give my telephone number also, my colleague and others. We have a team there. Just Dhaka Medical College Institute of Nuclear Medicine, our department. There are some instruction for the patient, and we need to collect the papers. We need to take the history of the patient. So that is very simple. Anybody can refer the patient. I mean, from the cardiologist, from the oncologist, anyone can refer the patient.
But one thing you observe that long queue there. There is patient takes 3 months, 2 months, 1 month time. So it is the so much frustrating for cardiologists.
Yes, yes. Yes, we can help. You must appreciate that in my center we are doing PET study twice a week now, on Monday and Wednesday. Just from this month, from February, we used PET research from our own resource. That is the great point. And I can accommodate your patient just one day MPI, another day PET. At the same day, it is not possible because radiation burden will be higher. That's why one Thursday, usually we do MPI, and next Monday, usually we do PET. And that patient will take his report on that week. I mean, only 7 to 10 days, patient will collect both reports. I think it is possible. That is the shortest time I can deliver the report, and there is not so long queue. and Professor Wadud Chowdhury sir referring several patients for the last couple of weeks. And from other corners, I got a good number of patients already, probably 32 cases already I did in my center. So that's why I am hopeful that from your support, I can continue my work, and I will try to my level best to deliver the report as soon as possible, because in a single day, 2 or 3 PET patient possible to do, because for cardiac patient there is a preparation. We have to use glucose. If patient is diabetic, it takes long time to prepare the patient. I mean, 45 minutes to 1 hour preparation time. Then after injection, it will take another 45 minutes. So patient will have to stay in our lab at least 2 hours for a PET study. So in that way, in a single day, we can do 2 or 3 PET. And for MPI, it is very simple. 4 or 5 cases we can accommodate in a single day. That's why I'm telling you the truth. I will try to my level best to accommodate your patients, patient, and I will try to deliver the report as soon as possible. No problem. Just refer the patient to Institute of Nuclear Medicine, Dhaka, and they will contact to room number 203. There is my colleague, and I also stay there. No problem. Directly, you can give my telephone number to patient also. They can contact with me. Okay.
Thank you, sir. Another question, Dr. Mohsin. Dr. Mohsin, do you hear me? Yes. Thank you for joining with us from Feni. Dr. Mohsin, yeah.
Sir, at first I would like to thank Shankar sir for his nice and brilliant presentation. I am working in Feni. It is a district hospital. So most of the patients here cannot go for the revascularization as early in the big cities. So some patients come to us even years after. I would like to give an example that I have a patient having 3 years ago triple vessel disease. At that time, he has ejection fraction about 40%, but now his ejection fraction is about 20%. And in the resting echocardiography, he has akinetic segment as well as some hypokinetic segment. So what will be our next step to this patient, whether we will go for the stress imaging or MPI or PET in such cases?
These are the cases Shankar was talking about. They need only rest imaging, rest PET and MPI. And that will be very helpful. These are the patients I was talking, they have hibernating myocardium. And you are not going to find out how much the patient can evolve after revascularization if you do only PET. That patient need FDG, PET scan to ascertain whether the patient will improve at all.
Sir, this patient having ejection fraction only 20 to 25%.
Actually, Shankar has been doing some of my cases who have ejection fraction like that. And I have done some intervention after with his guidance, and those patients have improved.
Yes.
This patient in Japan showed triple vessel disease.
Yes, sir.
Okay, but you put only one stent, saving the money of this patient, improve the ejection fraction. The idea is happening is getting the blood supply. So this patient cost is only 30,000 taka for PET or rest MPI, but he reduced the 2 stent price. That is 1,50,000 taka less reduce the prices, only giving the single stent. So at the end of the day, the reduce the price only 1 lakh taka. In the sense of 3 lakhs taka. Bypass surgery taking the 3 lakhs taka. So you just consult the patient's physician and the convincing them to send the Dhaka. So do the rest MPI and PET, and doing the only single stent into the patient is outcome. Wadud sir, just a comment.
Exactly. Great information, sir.
Can I make a
sir.
Before we send this patient for SPECT or for PET scanning, there are some simple clinical and echocardiographic measure by which we also make some deduction so that they are not overburdened. any decision that can be taken clinically and by doing simple echocardiography. In some cases, if the patient shows biphasic response in dobutamine stress echo, that also tells him by sure that this patient has got viability. So if you want to know about the viability, you have to go step by step. If the patient will have pain, then probably he has got viable myocardium. If there is absence of Q wave, probably he has got myocardium. If there is some thickening in the wall that is infarcted, there is viability. And if still you have the doubt, you can give small doses of dobutamine 5 or 7.5 milligram. And if the patient shows the biphasic response, then you know the patient has got viable myocardium. And by revascularization, you are going to get some benefit to this patient. And in some cases, when you have no motion in the wall after giving the dobutamine, then probably you need to know whether this person is viable or not. Particularly in that cases, possibly the PET will be the correct test. So we have to be really very choosy about sending our patient to nuclear people so that they are not overburdened. This is one point about the viability.
Yes.
But when you deal with
one question, sir.
Yes,
I want to put one question, sir. Mohsin, we did the echocardiography in the FINI. How echo can assess some type of viability for the 2D echo? Sorry, you comment, sir. Sir, Mr. Mashkar, sir. He did the echo, only echo in that FINI. He can give comments.
Yes. If there is any thickening of the myocardium, infarct-related myocardium, then it is viable. As you said that there were some segments that were hypokinetic. Those portions were viable. But if you are concerned about the akinetic portion, in that case, probably low dose dobutamine can help. If dobutamine you don't get any response and you have thought about that there can be some streak of viable myocardium, then probably these are the patients you can refer to. And not to forget about MRI. MRI actually we say PET is gold standard, but when we have discussion more on viability, we'll find the role of MRI in detecting viability cannot be understated. Actually, what in modern days are being saying that if a patient cannot go for MRI for one or other reason, probably the patient should go for PET. There are many equations, controversy there, but I want to give emphasis on another point, that is inducible myocardial ischemia. What is the role of MPI and what is the role of other modalities as regard inducible myocardial ischemia? I think some patient we need to know about the inducible myocardial ischemia. Regarding inducible myocardial ischemia, exercise echo is good enough, is as good as nuclear imaging, as good as MRI. If you just want to deal with whether the patient has got inducible ischemia or not. So exercise induced echocardiography, we have bicycle, but you can do it by doing the treadmill test, and you can put the if you have echo machine by your treadmill. It is really an excellent test. I have the experience of doing that test. It has got sensitivity which is equal to that of myocardial perfusion imaging by the nuclear guys. So there are few cases when we need to really their help, but in many of cases we ourselves as cardiologists with our equipment can.
Sir, I would like to ask, if the patient is improved with medical therapy,
yes,
some form of improvement of medical therapy, that can we say that there is the viable myocardium?
Can I add something about that? Actually, in a peripheral situation, I would suggest 3 things. Note the initial IPDI.
Yes, sir.
The wall thickness. Note the ejection fraction. Note the wall motion abnormality and which segments that are evolving. If the wall thickness, hypokinetic or almost akinetic segment, wall thickness is 7 millimeter or more, there is viable myocardium.
Yes, sir.
Can I add one point, Wadud?
Yeah, please.
Just by doing simple 2D echo, giving the emphasis on wall thickness and also the wall echogenicity, the reflectivity. So you decrease the gain of the machine, and if the endocardial shining is just close to the pericardium, it is a scar. There is no viability. So thin myocardium, less than 6 or less than 6 millimeter with high echogenic, it is already scarred. There is no viability.
And that's
thank you, madam.
helpful. Again, give proper treatment, including ARNI and including glyphogen, empowered dapagliflozin and beta blockers. You will find out, assess after 3 months, not very quickly. If there is reduction in the heart size, if there is increased wall motion, if there is akinesia going back to hypokinesia, improving to hypokinesia,
Yes, sir.
improving to moderate hypokinesia, improvement of ejection fraction, including improvement of the symptoms. And also, you will find out sometimes after giving treatment, the patient is complaining he now have exertional chest pain. Very surprising, but very assuring. You can be rest assured. This will improve by intervention. Either surgery.
Thank you, sir. We are passing around 2 hours time, sir. Excellent discussion. I think our
Mohsin, just one. Just 1 minute.
Comment, sir.
There was not a comment. There was a very good question to how to differentiate between the myocardial stunning and the hibernating myocardium. It was a question from our audience, from our fellow. Probably it is asked in the in the Viva code as well.
Yes, sir. I have asked the question, Dr. Shubro.
Yes. Professor Shankar, can you address the issue
of
Shankar,
differentiate?
Okay.
Shankar,
we need to have a separate.
Okay, right. Professor Shankar, last question.
Do that.
People should be hibernating and stunning by word.
Sir, that is very good question. Very good question. Actually, I worked with this. I worked with this in Japan. Actually, after acute myocardial infarction, within 30 minutes, they underwent that group of patients underwent emergency PCI, and on the 3rd day, I used MPI and a metabolic tracer. I mean, iodine 123 level BMIPP. That means free fatty acid analog. That is very expensive study I did in Japan. And as Mishka sir mentioned, stand myocardium. Stand myocardium means after myocardial infarction there is dysfunctional but viable myocardium. That is called stand myocardium theoretically. And I just wanted to analyze how extent or the size of the stand myocardium, how extent and how big it was. And depending on the dysfunctional viable myocardium, the size of the lesion and their outcome. I mean, in my study, after 3 months, after 6 months, I did echocardiogram. And I took the systolic and diastolic information data, and I observed the dysfunctional viable myocardium was larger and the improvement was more. I mean, perfusion and metabolism mismatch area was bigger. There was a chance of more improvement. And the perfusion metabolism mass defect, I mean, there was scarring and infarction already. There was infarction and improvement was less in that group of patients. That is one point. That is stand myocardium. So perfusion metabolism mismatch, if there is perfusion metabolism mismatch after acute myocardial infarction with the help of free fatty acid analog, that was clearly depicted the stand myocardium. And hibernating myocardium in case of old MI or ischemic cardiomyopathy patient, that is thinning of the myocardium. And if I go for perfusion scan, there is perfusion abnormality. But on FDG, I mean glucose analog, we can use here in Bangladesh, I mean fluorine 18 FDG, or in Japan, I observed if there was an iodine 123 level BMIPP, whatever else. So in chronic ischemic area, I mean in chronic ischemic cascade leading to ischemic cardiomyopathy or dilatation of the LV cavity, there was perfusion and metabolism mismatch that depicted clearly the hibernating myocardium. So that is the two ways we can differentiate. And our earlier way, another observation is LV cavity dilatation is observed in case of stand myocardium. So these are the ways we can differentiate the stand myocardium and hibernating myocardium. I think it would be clear to you all.
Thank you all. Thank you. We have to conclude our session today because we midnight. Thank you all the participants, panelists, especially Dr. Prof. Shankar Kumar for excellent deliberation in this discussion. Thank you, Incepta Pharmaceuticals. They are with us till midnight. Next month on the March, we have month of stress. That is stress ECG, that is excess tolerance test, and Dobutamine test. On the 5th March, Friday at 10 p.m. We'll talk on excess tolerance test, and 19th March, stress echo. Goodbye. Officer Wadud sir, please conclude the session.
I think today's lively discussion and the beautiful presentation has proved my point. Professor Shankar has really enlightened every one of us. Many thanks to you. And the audience has responded very nicely. We also want to know whether and how my patient will be best served. And your contribution in this regard will be very helpful for a very sick group of patients. And I hope the next month, the use of stress evaluation in defining ischemia, in defining viable tissue, in identifying potential area of intervention, all this will be much more demonstrated, and it will make us everyone much richer in knowledge. Thank you, everybody. And
thank you, sir.
Thank you, Saurabh. Thank you, your team, for staying with us for such a long time. And we are
thank you, sir.
But mostly, I think all of us should give a clap to him. He's such a hardworking person, deserving so much of his time. He and Shajol, I salute him, both of you.
Thank you, sir. Thank you, sir.
And good night.
Thank you, sir. Assalamualaikum, sir.
Assalamualaikum.
Assalamualaikum,
sir.
Assalamualaikum, sir.
Madam, Allah Page. Shankar.
Good night, sir.
Thank
Good night,
you,
sir.
sir. Good night, sir.
Allah. Good night. Ajay. Good night, Ajay. Arif. Allah Page.
Thank you, sir.
Professor Shankar, very impressed. We are.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you, sir.
Mr. Shankar, always our best friend. Always he's worked with us last 54 years. Shankar, thank you.
Thank you, sir.
So much.
Thank you, sir. Thank you for your support and giving me that opportunity to present here. Thank you, sir.
Thank you, sir. Thank you, sir.
Madam, Assalamualaikum. Thank you, Incepta and Saurabh. Thank you so much.
Thank you, sir.
Good night.
Madam, দেখা হবে।
Allah Hafiz.
Thank you, sir.
সবাই ভালো থাকবেন, সবাই ভালো থাকবেন।
থ্যাংক ইউ।
হ্যাঁ দাদা, নমস্কার দাদা, ভালো থাকবেন দাদা। থ্যাংক ইউ দাদা।
আসসালামু আলাইকুম স্যার। থ্যাংক ইউ স্যার।
স্যার আপনাকে অনেক ধন্যবাদ স্যার। স্যার আপনাকে ওয়াদুদ স্যার, আপনাকে স্যার অনেক ধন্যবাদ স্যার, আপনাকে এই সুযোগটা করে দেওয়ার জন্য আমাকে, এবং আমার যে কেসগুলো স্যার আপনি পাচ্ছেন এবং আমার রিপোর্ট কেমন হচ্ছে এগুলো আপনি যদি আমাকে ক্রিটিসাইজ করে জানান, আমি আমাকে আরো ইমপ্রুভ করতে পারবো স্যার। আপনাকে অনেক ধন্যবাদ স্যার।
পরে আবার পরে পাঠাবো, জাস্ট এমপিআই তুমি করে দিবা, প্রবণ তোমার নিজের
স্যার। আমি একটু লাস্টে স্যার এটা প্রেজেন্টেশনের বাইরে স্যার, যে ডায়াবেটিস স্যার আনকন্ট্রোল থাকলে স্যার এটা কি পাঠানো যাবে, এবং রেনাল ইম্পেয়ারমেন্ট যদি থাকে স্যার সেক্ষেত্রে স্যার কোনো বার আছে কিনা স্যার?
এইটা একটা বড় প্রশ্ন, কারণ আমরা যখন গ্লুকোজ লোডিং প্রোটোকলটা ইউজ করছি ডায়াবেটিক পেশেন্টদের জন্য চ্যালেঞ্জিং হয় যদি আগে থেকে ডায়াবেটিসটা কন্ট্রোল করা না থাকে। এই জন্য বেটার হচ্ছে পেশেন্টকে যদি ডায়াবেটিস থাকে ভালোভাবে গ্লুকোজ কন্ট্রোল করা, অর্থাৎ হিমোগ্লোবিন A1C যেন 6 অথবা তার থেকে কম থাকে, এবং আমি যখন গ্লুকোজ লোড করব যদি গ্লুকোজ লেভেল লেস দেন 150 মিলিগ্রাম থাকে তাহলে আমার স্টাডিটা ভালো হয়। কারণ আমি কি করি, আমি বিলো 150 মিলিগ্রাম যাদের গ্লুকোজ লেভেল থাকে ডায়াবেটিক পেশেন্টদের, তাদের আমি মাত্র 25 গ্রাম গ্লুকোজ লোড করি এবং সঙ্গে আমি 3 ইউনিট রেগুলার ইনসুলিন ইনজেক্ট করে দেই। কিন্তু যদি গ্লুকোজ লেভেল অনেক হাই থাকে, আমি 45 মিনিটস আফটারও যদি দেখি তার গ্লুকোজ লেভেল বেড়ে গিয়ে 150 ক্রস করে যাচ্ছে, তাহলে কিন্তু আমাকে আবার ইনসুলিন দিতে হয়, 3 ইউনিট দিয়ে আবার তাকে ওয়েট করতে হয় কিছুক্ষণ। এই হ্যাসেলটা ওভারকাম করতে গেলে বেটার হচ্ছে পেশেন্টকে আপনি গুড কন্ট্রোল অফ ডায়াবেটিস এটা রেখে আপনি আমার কাছে পাঠাবেন। এটা হলো একটা কথা।
তোমাকে একটা প্র্যাকটিস নাম্বার 1
রেনাল ইম্পেয়ারমেন্ট নিয়ে কিছু আছে স্যার?
কোনো কিছু নাই। রেনাল ইম্পেয়ারমেন্ট পেশেন্টদের ক্ষেত্রে কোনো কন্ট্রাইন্ডিকেশন নাই পেট সিটি করার জন্য বা এমপিআই করার জন্য। নো কন্ট্রাইন্ডিকেশন, ইউ ক্যান সেন্ড এনি টাইম, নো প্রবলেম।
আমি একটু ইন্টারফেয়ার করি শঙ্কর।
হ্যাঁ স্যার।
ব্লাড সুগার কন্ট্রোলের ক্ষেত্রে ডু নট এক্সপেক্ট দ্যাট তাই HbA1c 6% নিচে হবে, নেভার। অলমোস্ট ইউ ক্যান এক্সপেক্ট ইটস 7.5 or 10%. But to tell the patient to fast for a long time, at least 8-hour fasting, 8-hour, 10-hour fasting. That will be helpful for you.
আচ্ছা স্যার, আমরা যেটা করি অনেক সময় পেশেন্ট কি করে, পেশেন্ট অনেক সময় বলে যে কতক্ষণ ওয়েট করতে হবে কি নাকি, আমরা ওই পেশেন্ট গুলোকে মানে যেহেতু আমরা গ্লুকোজ দিয়ে কাজটা করছি, ওনাকে বলি যে আপনি ভোরে 6টা বাজে একটা ডিম খেয়ে আসবেন। পেশেন্ট হয় কি সাইকোলজিক্যালি অনেক সময় উইক হয়ে যায় যে আমি সারাদিন না খেয়ে থাকবো, 11টা পর্যন্ত না খেয়ে থাকবো, দুর্বল হয়ে যাব, এটা একটা জিনিস। তা পেশেন্টকে যদি আমরা ওভারনাইট ফাস্টিং রেখে, ডায়াবেটিক পেশেন্টদের আপনি যেটা স্যার বলছেন এটা খুবই ভালো কথা, যে আমার শুধুমাত্র হিমোগ্লোবিন A1C না দেখে তাকে যদি আমি ওভারনাইট ফাস্টিং রেখে সকালে আমি যদি 10টা বাজে আমি তাকে যদি গ্লুকোজ লেভেল গুড কন্ট্রোল কন্ডিশনে পাই, সেটা আমার জন্য স্যার বেশি বেনিফিশিয়াল হবে। এটা ঠিক আছে স্যার, আপনার কথাটা অবশ্যই স্যার, এটা ঠিক আছে, আমি দেখবো স্যার।
ঠিক আছে ভাই, থ্যাংক ইউ
স্যার।
আসসালামু স্যার।
স্যারকে আমি বলছি স্যার একটা পেশেন্ট পেয়েছিলাম মাঝে, তার গ্লুকোজ অ্যাকুমুলেশন হচ্ছিল না। তার মানে কি ওই পেশেন্টের, আপনাকে স্যার আমি মেসেজ করেছিলাম, ওই পেশেন্টের যেটা আমি জাপানেও দেখেছি যে তাদের যে ফ্রি ফ্যাটি অ্যাসিড যে অ্যাকুমুলেশন হয় স্যার, CD36 রিসেপ্টর মায়োকার্ডিয়ামে অনেক সময় থাকে না। আমি 100টা পেশেন্টের মধ্যে আমি কয়েকটা পেশেন্ট পেয়েছিলাম, 3টা পেশেন্ট পেয়েছিলাম যাদের BMIP অর্থাৎ ফ্রি ফ্যাটি অ্যাসিড অ্যানালগ অ্যাকুমুলেশন হয় নাই। তখন আমার স্যার আমাকে দেখালেন যে এই পেশেন্ট গুলো হচ্ছে তাদের রিসেপ্টর অ্যাবনর্মালিটি আছে, যারা ফ্রি ফ্যাটি অ্যাসিড নিতে পারলো না, এরা গ্লুকোজ নিয়েই সারা জীবন বেঁচে থাকবে। আর আমার সেন্টারে আমি যেটা পেয়েছিলাম যে তাকে আমি 2 দিন চেষ্টা করেছিলাম গ্লুকোজ লোডিং প্রোটোকল ইউজ করে, এবং যেভাবে স্ট্রিক্টলি মেনটেন করা হয় সমস্ত কিছু, কিন্তু আমি পারি নাই। তার অ্যাকুমুলেশন খুবই কম ছিল, ব্যাকগ্রাউন্ড অ্যাক্টিভিটি অনেক বেড়ে গেল। এদের স্যার যেটা হয়, শরীরে ফ্রি ফ্যাটি অ্যাসিড লেভেল অনেক বেশি থাকার জন্য গ্লুকোজ আপটেক অনেক সময় হয় না, কম্পিটিটিভ ওয়েতে তো এটা অ্যাকুমুলেশন হয় সেলের ভিতরে স্যার, এটা হয় না। তা এই একটা পেশেন্ট আমার এক্সপেরিয়েন্স যেটা গত কয়েক মাসের মধ্যে, যে পেশেন্টটার গ্লুকোজ আপটেক খুবই কম হয়েছিল। এছাড়া মোটামুটি ডায়াবেটিক, নন ডায়াবেটিক সব পেশেন্ট গুলোরই মোটামুটি আমাদের ভালো রেজাল্ট এসেছে স্যার, খুব সুন্দর ইমেজ এসেছে, কোনো অসুবিধা হয়নি স্যার।
মতিন, ওই যেটা বললাম যে এই যে ভায়াবিলিটির যে ব্যাপারটা, আমাদের অজয় অনেকদিন ধরে এগুলা নিয়ে কাজ করতেছে। তোর যখন পার্সোনাল কোনো পেশেন্টের সন্দেহ কি থাকে, ওর কাছে ফোন করে কিন্তু তুই একটু উপদেশ নিস।
আচ্ছা স্যার। জি স্যার।
আর ইন্টারেস্ট আছে অনেক আগে থেকে, আমি হার্ট ফেলিয়ার পেশেন্ট সারা দেশ থেকে আমার কাছে সবচেয়ে খারাপ পেশেন্ট গুলো আসে, সেইগুলাকে ধরে ইমপ্রুভ করি, তারপরে গিয়ে এনজিও করে তারপরে ইন্টারভেনশন আদৌ যদি লাগে করি। আমার বহু পেশেন্ট ফ্রম 25% to 55% এরকম প্রচুর পেশেন্ট আছে। এবং
আর্নি আসার পর থেকে স্যার কিন্তু স্যার এগুলো ইউজ করার পরে ইনজেকশন ফ্রিকশন স্যার ভালো ইমপ্রুভ করেছে।
ঠিক, আর্নি এবং সাথে গ্লিফ্লোজেন। ডায়াবেটিক পেশেন্টও যে 10 মিলিগ্রাম করে এম্পাগ্লিফ্লোজেন দিতে পারো, এটা যে কত উপকার you can't imagine. But always look for anemia, look for hypothyroidism, for renal impairment, and COPD. You improve all those factors. The patient. এটা খুব ইম্পর্টেন্ট জিনিস।
স্যার একটা জিনিস একটু মানে রিয়েল
আমি এখন
আলাপ করি স্যার। অ্যাকচুয়ালি যদিও সময় হয়ে গেছে, অ্যাকচুয়ালি আমরা তো এমপিআই পাঠাই সাধারণত সিভিয়ার এলভি ডিসফাংশন পেশেন্টের ভায়াবিলিটি দেখার জন্য। এটা একটা সিনোনিমাস হয়ে গেছে যে সিভিয়ার এলভি ডিসফাংশন তাকে ভায়াবিলিটির জন্য পাঠানো হয়। সেই ক্ষেত্রে যদি এমপিআই জন্য ভায়াবিলিটি পাঠানো হয়, সেক্ষেত্রে কিন্তু স্যার প্যাট ছাড়া কোনো গতি নাই। হ্যাঁ, তো আমরা স্প্যাক্ট করে দিয়ে দিচ্ছি, মানে স্প্যাক্ট নিয়ে আসতেছে। তো তো আমরা চাচ্ছি কি আসতেছে কি এই জায়গার মধ্যে কিন্তু এটা মিসম্যাচ হচ্ছে কিন্তু আমাদের মধ্যে ইয়ের মধ্যে এটা কিন্তু আমরা যারা পাঠাচ্ছি
পারছি না
স্যার থ্যাংক ইউ স্যার। আসসালামু আলাইকুম স্যার।
থ্যাংক ইউ স্যার। ওকে